Hey, good evening, everyone. It is Monday night, 7 o'clock, and I just want to thank you all for deciding to attend this course. I'm a general dentist, and I didn't really have any experience with dental implants when I first became a dentist 17 years ago. And of all of the things I've learned, and some of you have been dentists for as long as me, some of you are veterans like I am, we learn a ton of stuff. We learn a ton of CE. You go to courses about TMJ, you go to courses about aesthetic stuff. And I went to those courses and I tried things out. And I truly, genuinely believe that implant overdentures, of all the stuff that I learned about, implant overdentures is truly the most profitable and most gratifying of every dental procedure I've ever done. And hopefully, what I'd like to do tonight is show you why I feel that way, number one. And number two is to make you feel, especially those of you who've never done an overdenture, who've never restored one, who find it intimidating, for you to feel like, wait a second, that's not as bad as I thought it was. And maybe you'll feel comfortable restoring a few cases in the next few months, because there's a huge, huge number of patients out there that hate their denture and they really want a solution, but they're not really ready to pay for some all-on-6 or all-on-4 fixed prosthesis. And implant overdentures are just a wonderful option for those people. One thing I want to make sure everybody knows is everything that I do, every lecture that I've ever done, I don't know if some of you might be on this call who have attended some of my lectures in the past. All of my lectures, I put very high-level handouts on my website, BeBetterSeminars.com. You don't have to enter your email address. You don't have to sign up for a membership. You don't pay anything. All of my lecture handouts are on my website, and I'll have my website up again at the end of the slide. You can print them out, and then you can use them for reference. The next time you do an implant case, maybe it'll be your first surgical implant, maybe it'll be an implant retained denture. I want you to have these resources available to you. So what is an implant retained removable overdenture? I want to make this clear because there's a lot of words out there. There's words like all-on-4 and all-on-6 and fixed hybrid and all of that kind of stuff, implant bar overdenture. I just want to make sure that what I'm talking about is something that you can easily define. Okay, so I want you to think of an edentulous space, and coming out of that edentulous space looks like a little trailer hitch, okay? So a little edentulous space with something that we call a locator emerging from the gingiva. And then, so that's our little locator. There's an edentulous space and there's some trailer hitch called a locator coming out of the gums, okay? Then inside of the denture, there's something called a retention cap that snaps into that locator. So in the earlier picture that I showed, it showed two locators on a lower edentulous arch. And here you have a denture that has two retention caps that are fixed inside of it. And those retention caps are now going to snap in to that locator. Here's an example with a partial denture where that person still had a tooth, where you can kind of see my glove there. A person has a tooth there, but next to that tooth is an edentulous space, and there you have a locator a retention cap that'll snap into a locator. And this allows the denture to actually snap in, as opposed to any denture that these people have ever experienced before. Before, they had dentures that were held in either by the suction of their palate or held in just by the how robust the arch on the lower arch was. This allows the denture to actually snap in. And it's awesome because when you have a denture that snaps in, all of those rules that you learned in dental school about how to retain a denture, how to maintain retention with a denture, all of those rules become irrelevant. I mean, I remember in school, in order for an upper denture to really snap in, not snap in, but really suction in there, you needed to have really good vestibular extension and palatal coverage. Same thing with the lower. The lower, in order for a lower denture to stay in, you have to really extend it into the vestibule so it kind of stays in there. This eliminates all of that. So a lot of my upper implant retained overdentures, those have no palatal coverage. I make them horseshoe shaped. And I'm actually surprised at how much of a relief that is for a lot of my patients that truly cannot tolerate full palatal extension, full palatal coverage. And if you notice in this picture, you notice that I'm not even extending over the hamular notch. This is a patient that gags a lot and wouldn't have been able to tolerate palatal coverage. And then when we're talking about partial dentures, an implant retained removable overdenture, it eliminates the needs for clasps around natural teeth. And that's great because we all know what those clasps do over time. They ruin the teeth that they're clasped onto. And now instead of having a partial clasping onto teeth, you have a partial that snaps into those locators. So here's an example.
Yeah, go ahead and remove them. Okay, show us your hardware. Show us your hardware. Pull your lip down. Yeah, there we go. Okay, now put it back in. Okay, now show us how difficult it is to remove them. There we go, thank you.
So the hardware that you saw there, this gentleman, he has two lower traditional implants with locators in the back. And then the two implants in the front were actually those one-piece O-ball implants. I used those for a long time in my career. I don't use them anymore. And I'm willing to talk about why I don't, but just for the sake of time, I want to respect everybody's 1 hour on this webinar. I'm not going to talk about those O-ball implants, and I'm mostly going to talk about locators that go on top of traditional implants. Okay, so why else are these so wonderful? It's awesome to get a patient to snap in a denture and have a little bit of difficulty removing it. That's a cool feeling. But why else are they nice? Well, for a fully edentulous person, lower dentures suck. I mean, for me, I've been a dentist for 17 years. A fully edentulous lower denture, man, I could take every course out there. I can just try my best. And it's really difficult for me with certain types of arches to get a full lower denture to actually be retentive. And that's a really sucky feeling. You charge a bunch of money, you put a patient through several appointments, and then they have a lower denture that flops around, and that's a bad feeling. And then the other thing is, like I said earlier, some patients, they just can't tolerate or they don't like full palatal coverage on the upper. That's one reason why implant overdentures are nice. Here's a guy. Look, I put in his denture. This is. Hang on. Let me hang on there. This guy, this example. This is a traditional denture. So this guy has no implants. Look at how he tolerates this denture that I made him.
What's wrong?
I just felt out of that air.
Is it hard to keep those in?
It just
Okay, I can tell it's hard to keep those in. Okay.
So he didn't yak, in case any of you are wondering. He didn't throw up in the chair, but we were like really ready for him to throw up all over us. This would be an impossible case. Wouldn't you agree? If you didn't have the added knowledge of implant overdentures, this would be an impossible case. And that would be such a shame because this is a very nice gentleman. And that regular denture that I made him, there was no way he would keep that in his mouth. For partially edentulous people, well, clasping is ugly, especially when you can see the clasping around anterior teeth, and clasping ruins abutment teeth. And for both, I know that I attend a lot of courses that talk about how awesome fixed cases are, all on fours and all on sixes. And the concept of an all on four, this is a fixed case. This is something that never gets taken out. The concept is extremely awesome, right? It's like giving a patient a new set of teeth and they're fixed and they never have to remove them. It's a great feeling. The only problem, the limitations that all on four and all on six have is they're very expensive. And the other problem is they require long-term success of the implants. Now, I want you to think about that for a second. The reason people are edentulous is because they don't have the best habits. Let's face it, a lot of the reasons that you have an edentulous patient is because they don't take very good care of their teeth. And so it's an unfair assumption to think that, well, they didn't take good care of their teeth, but they're going to take really good care of these implants. Sometimes that's not the case. The other reason is that a lot of people lost their teeth because of a smoking habit. And so I think everyone on this call knows that implants, they don't succeed as well when a person smokes. And so we need, if we're doing an all on 4 or all on 6, that requires that the implants succeed long term. And you don't know that. They're also difficult to clean around and under. And then what happens if a tooth breaks or if an implant fails? Or what if the gums recede and you can see some of that implant body? Those are all really valid concerns when taking on an all-on-4 or an all-on-6 case. I do a lot of those cases, and they cause me a lot more anxiety than I like them to. However, these implant retained overdentures, they don't cause that anxiety. They're more fun to do. Okay, and why else? They're so profitable. So here's a little chart that I made. The cost, the amount that I spend for a surgical guide to place the implants, the 4 implants that I place, the 4 locators, the caps, the housings, the immediate denture, and the complete denture. The cost. Now, the cost of that complete denture, I'm using a particular lab. It's the lab that sponsored this event. And I'll go in more detail about this lab later. But then this is what I charge. I charge a lot more than what I spend. And my profit is really nice. That's a nice profit for something that doesn't require several steps. And I'll explain why it doesn't require several steps in a few slides. It's profitable. And lastly, it's incredibly satisfying, incredibly satisfying. Feeling a patient who's struggled with dentures their whole life, or talking to a patient who's afraid of having a full denture and allowing them to snap it in, it's really satisfying. Snap them in. There, I heard the snap. Is there anything you can't eat?
No. I can eat anything I want to eat. I can eat anything I want to eat.
That's great. Now, really, look at how adorable this guy is. I mean, he's like the cutest dude ever. And there was no way, I'm just not a good enough dentist to make him a lower denture that would have stayed in. As you could tell, his arthritis, his Parkinson's, those were pretty serious. His mouth movement and his involuntary muscle movement, it wouldn't have allowed a lower denture to stay in. And now this guy's happy. He can eat whatever he wants. So let's talk about the steps. How are you going to actually do this in your office? What I can't talk about today, just because of time, is I'm not going to talk about the surgery, the surgical guides, the bone grafting, the manipulation of tissue. I would love to, but I have an hour. I am doing a lot of hands-on courses this year, and I'll give you more information about that at the end of this, but I can't talk about some of the cool surgical stuff. I'll talk about those in some of my courses in the future. So, there's my website. If you want to learn about some of my hands-on courses that I have coming up this spring and this summer, you can visit my website. Okay, what we will be able to talk about, all the pieces and parts and the techniques using simple language from the time when implants are integrated all the way to the time of final seating. And then I will mention a little bit about retention and maintenance. Okay, so now you have a patient. They've had the implants done. Either you placed them or your oral surgeon placed them. They have a healing denture in place. Okay, so now here's that patient. They have some denture. They have some implants. They're integrated. They're all those implants. They're nice and stable in the mouth. Then they're wearing a temporary denture. So they come to you. Now, this is a person that doesn't have healing caps. So I had to go and retrieve them. I used my laser to remove some of that overlying tissue, and I found the implants. So what do you do now? This patient now has a temporary denture, and it's time for you to start attaching your locators onto those implants. What I would recommend you do is wait on fabrication of your denture until you have your locators in place. So remove the cover screws or the healing caps, and then attach your locators as long as you can predict the cuff height. Let me explain what I mean by that. So The cuff height is this. If you notice here, you have the height of the gingiva. Okay, so we'll call it the gingival crest. That is basically where the gingiva, the top part of the edentulous arch. And then if you look a few millimeters below that, there is the platform of your actual dental implant. This is a Megagen any ridge implant that you're looking at. Your cuff height is the distance from the crest of the gingiva to the platform of your implant. That's your cuff height right there. And this is important because you need to determine your cuff height with a perio probe or something like that in order to know which locator you're going to screw in and attach to your implant. So you order the appropriate size locator, and every locator out there, whether I place Megagen implants, you might place Straumann implants, another person might be placing Zimmer implants, it doesn't matter. Locator has the correct and compatible locator. Zest has a compatible locator that goes into your implant. What you need to do, though, is determine what cuff height to actually use based on that earlier measurement. If the length of the locator coming out of the gingiva is too short, so let's say you pick a cuff height that's too short, it's going to be too short. It's going to be buried under your gums and you won't be able to snap in your attachment. If it's too long, then it's going to be too long and the underside of your denture is going to be compromised and you'll end up with, so that one is perfect right there. See, there's a locator coming out of the tissue and now you can snap on a metal housing perfectly. It's like exactly 1 millimeter coming out of the tissue. It's awesome. The metal housing snaps on perfectly, you're all good. But what if it's too long? Then you might drill a hole through your denture. This is a brand new denture, and I drilled a stupid hole in it because I had a locator that was too long. So determining the cuff height is really important, okay? So now you've attached a cuff height to all of your implants in the edentulous space. Your temporary is not going to fit. Now you have a stupid locator coming out of the gingiva on all of those implants and your temporary will no longer fit. And this part is, in my opinion, the most challenging part of this entire process. So you have two choices. Choice one, you choose the appropriate cuff height, you torque it into place, you snap on your metal housings, and then you take an impression or a scan, okay? But the problem is, now, what do you do after that? After you take your impression or take your scan, is you have to remove all that crap. You have to remove those metal housings. You have to remove those locators so that the patient can wear their temporary denture again. And the problem with that is that removing all these little things and saying, okay, wait a second, I think the implant number 3 had a 2 millimeter cuff height and the implant that was in the area of 7 had a 1 millimeter cuff height. And then you put it in a little baggie, but the baggie has to be labeled. This really requires a nice system of organization and mistakes. It's easier to make mistakes this way. So this is choice number 1. And I don't love it, but it's a choice. Choice number 2 is you do the same thing. You choose the appropriate cuff height, you snap on the metal housings, and then you take your interim denture and you adjust the crap out of it, okay? And at this point, you have to adjust the underside of your interim denture so that it fits around those metal housings that you just snapped in. I'll show you a picture in a second. Then take that interim denture and put light body PVS inside of it and take a 360 scan with a digital technique. And I'll show you that in the next slide, okay? What's really cool about this is if you do this right, you can skip all the way to the try-in. Seriously, you can skip all the way to the try-in. The only problem with it is that adjusting your interim denture totally sucks. But skipping all the way to the try-in really unsucks. So here we have a patient. This patient has those locators and then metal housings. And then if I had my chat on, I would ask you, why is it all purple? But I don't have my chat on. The reason is I use those little ink sticks you know, those ink sticks that we use sometimes if a patient needs their denture adjusted. I used that ink stick and I colored the metal housing so that, and then I tried in my denture so that I would know where on the denture to adjust. And you can see now this person has a denture and kind of these two hollow areas. And I'm going to tell you right now, this part is really difficult. It takes a lot of time. And sometimes you're adjusting in the wrong spot. And I have a couple aids to help you with that, and I'll talk to you. But the digital opportunity is awesome. So you put in your locator, you snap on the metal housing, and then you take a PVS impression of the denture, and you have the patient bite it in place because they have their upper and lower interim denture. And then you take a scan of the whole thing. So here we have, this is her interim denture. What we're doing is taking a scan of the interim, and then we're taking the scan of the inside. If you notice there, for some reason, I was an idiot and I didn't snap in the metal housing. So you can see that I only scanned the locators. That's okay. Now what the lab can do is they can go all the way to try-in. What they're going to do is fabricate either a metal framework with PMMA acrylic already attached to it. And as you can see here, because I was able to take a scan of the denture showing where those implant locators are, those areas are already adjusted. Now there's not going to be as much guesswork for you when you're trying it in. But this requires a couple tools. And let me tell you about those tools. First of all, in order to adjust the inside, the underside, it's called the intaglio surface of your denture, you don't want to just use a big, beefy lab burr. I did that for years. Then the problem is sometimes you just drill a hole through your denture inadvertently, or you drill too much. You really need a burr that's the exact size of the metal housing for your locator that's going to go in that space. And Zest makes a really nice burr. It's this one right over here. It's the exact size of the metal housing. I'm going to show you that in action on this denture right now. Okay, and then let's create some undercuts. You can, okay, so this is another burr. This is another burr that's in that same setup. And if you notice, it's a reverse taper. Because it's a reverse taper, it's going to create undercuts so that your pickup acrylic will actually lock in. Okay, so let me go back to that slide from before. This one right here, this is a really nice kit. It's wonderful. It helps in a lot of ways. But there's the burr that actually is the exact size of your locator metal housings. And then there's the burr to the right of it. And that creates undercuts so that when you pick up your metal housing, and I'll show you that in a second, when you pick up that metal housing, the acrylic that picks it up will lock itself into those undercuts. And so that way that metal housing has a much better chance of actually staying in place. Okay? Skip over this. All right, so now you're at this point. You have a denture and you love your denture. You have a denture that already is hollowed out on the inside so that it fits around not only your locators, but also your metal housings. And so a lot of you are like, awesome, sweet. Let me go ahead and pick up those metal housings and I'll be good to go. But I want to stop you right here. And this might be, you know how I said that adjusting your interim is the biggest pain in the butt? It is. But this next part is the one part that, you know how I said that this is a low stress, it's a wonderful procedure, it's profitable and it's gratifying and all that great stuff. This is the one part that makes me the most nervous, okay? So let's review here. You have an edentulous space with locators attached emerging from the gingiva. Okay, so there's the locators, they're emerging from the gingiva. You have a beautiful new denture with space blocked out around the locators. So here, this is that denture that it was a beautiful, it fits so nicely. And then I drilled a stupid hole. You can see that on the left side of your screen when I was making room for the locators. If you notice here, this is a denture that I did before I bought that kit from Zest. And you can just see that area that I hollowed out, it's more clunky, it's more sloppy. And that's why I made the mistake, okay? So now you must snap in your metal housings. Okay, so here I snapped them into those locators, and you have to block out undercuts. So what I said, the one thing that makes this nerve-wracking for me is right here, the undercuts. Let me explain what that is. Any area of the locator cuff that hasn't been covered by your metal housing, any threads of the implant, and I'll show you that in a second, or any part of the implant body, or any of the adjacent teeth. Those are undercuts. You know, I'm going to go back to a slide here that I showed you. Where was it? Here it is. Okay. It was that cuff height slide. It was so cute, right? So you take oh wait, it was this next one. Here it is. So ideally, you want a locator that looks like this. 1 millimeter of the locator body coming out of the gum. It's perfect. And then when you snap on the metal housing, it's perfect. Like, all you're going to do when you try to pick up that metal housing is you're going to get acrylic around that metal housing. It's a thing of beauty. But the problem is real life isn't always like that. Real life isn't always this thing of beauty. And I'm going to show you that right now. Okay. So let's go back to the slide that we were in where it's not perfect. So you have your metal housings, they're snapped on. What if you have a case like this one here? This is a gentleman, he's been my patient for over 15 years, and he has had failing dentition throughout the entire process. He's very, very uncomfortable with anything, any type of removable denture. And so over the years, when he would lose a tooth, we would place an implant. But the problem was that he would just lose more teeth. And one of the big reasons why was he just had a very, very poor oral hygiene habits. And you can kind of see that. Just looking at this slide, you can see that. Poor oral hygiene habits. And if you would look at that front implant, the one that is on your right, the patient's left, you notice that there's implant thread that's showing. Can you see that? There's implant thread that's showing. So now I want you to imagine if I put a bunch of hard acrylic around that locator, what would happen? That hard acrylic would find its way onto those implants threads, wouldn't it? And then what would happen once that acrylic hardens up? I wouldn't be able to pull the denture out. It would be locked on for good. Can you imagine what your day would be like if you're trying to snap off an implant retained denture and you can't, and you're grabbing it and your fingernails are getting under the stupid thing, trying to pull it off? This is a nightmare. And so blocking out your undercuts is incredibly important. Here we have an adjacent tooth, and the adjacent tooth has a height of contour. And if acrylic hardens up under that height of contour, it's going to lock in place. Here we have an implant that's it's not the right angle compared to the rest of those. This one, it's going to create an undercut. And if it does, you're screwed. You're not going to have a very long lunch that day because you're going to be busy trying to drill off a denture. I've done it twice. I hope I never do it again. And I really hope that all of you who are listening in right now, 761 of you, none of you ever have to drill off a denture because it's the worst. You're going to think about it for a week afterwards. So blocking out your undercuts, it can be done in 3 ways. Number one is with a rubber dam. And the rubber dam is probably my favorite That's where I cut off a centimeter by centimeter square of rubber dam, and then I put a hole right through the center. And if you notice here on that patient's name is Paul. He's a super cool guy. I used rubber dam, and then I also used this stuff called blockout paste. That's also sold by Zest. And basically, it's very similar to Tempit. Those of you who do root canals, Tempit is just that stuff that after you say start a root canal but don't finish it, you'll squirt Tempit into that access and then wet it with like a cotton tipped applicator, and it hardens up. This stuff I think is almost identical. But what I'm doing here is I'm smashing that stuff around the undercuts so that my acrylic can't ooze under those undercuts. And you see I have it around adjacent teeth. I have my rubber dam kind of flowing up around the adjacent teeth so that acrylic can't ooze under any of the undercuts. There's also something called a blockout ring. A blockout ring I would recommend for your really, really simple cases. The cases like the one that I exemplified earlier, where that locator is just perfect and the metal housing is just perfect, and you just want a little bit of protection, put in a blockout ring, okay? I noticed somebody did do a question on the Q&A. I do welcome questions. There are quite a few of you, and I'm gonna make sure that we have 15 minutes at least by the end of my presentation so I can answer some of these questions, okay? So now it's time to pick up your locators. So you have your denture, here it is. Here's the denture. Most all of my dentures, I make them metal frameworks just because they're not as big as traditional dentures. So if you notice here, I have a denture metal framework, and I have the areas hollowed out that are gonna go around the metal house.
Okay. Over the second time.
Yeah.
This is adhesive. So now I'm just drying the adhesive.
Now we can't look, but my phone can look.
Okay, so I cure it, the adhesive, and then I take hard acrylic. It comes in a gun.
Oh, yeah, sorry.
Show the bleed out.
Oh, yeah.
Because that was a
Oh, yeah.
huge. How long did it take us to figure that out?
And now what I've done is I've just filled in those wells where we've hollowed out the inside of the denture. And then we seat the denture fully. And I like to ask my patient to bite down a little harder than they normally would. Bite down just a little bit harder. They don't have to hurt themselves, but just to bite down a little bit harder. Really make sure that that denture is seated all the way. Now, one thing that I notice as I've gotten older is sometimes along with adding acrylic in this area, I also maybe might put a little bit of acrylic around those locator metal housings, okay? And then after that denture has been seated in the mouth for about 5 minutes, the acrylic has completely hardened up. And when you pull the denture off, it should look the denture out, it should look something like this. If you notice here, this is the original underside of the denture. And then you can see this newly hardened acrylic. And now you have your metal housing and your retention cap that very smoothly was picked up. Now, it's not always that smooth. As you can imagine, a little bit of that acrylic must have oozed somewhere. I mean, it didn't only pick up the locator metal housing. So, I'm going to tell you the story about this one in just a second. But I do want to emphasize again, when you have extra flash of acrylic, just use a nice kit to remove that flash and to polish everything up. All right, so what do you all think that I'm pointing to on the right side there? Oh, wait, we can't do the chat, darn it. All right, Well, that's an implant right there. That is an implant. This was, I think this was still better than if I had to drill the denture off. To be honest, I think it's still better. The patient wasn't too happy that I literally ripped an implant out of her mouth when I tried to remove the denture, but it was probably an implant that was doomed to fail anyway, given that it came out in that way. But this was a situation where I must have just not blocked out enough. And then underneath that, you can see how some of the acrylic actually picked up the rubber dam that I was using to block out the one next to it. So again, blocking out is so incredibly important. All right, so now you have the denture for the first time.
I ate corn on the cob, first time in 2 years, and it was good.
Incredibly gratifying, incredibly gratifying. Here, let's hear that click one more time. For the first time.
I ate corn on the cob, first time in 2 years, and it was good.
You know what's crazy? I look at this video and I don't know what I was smoking when I marked the midline. I mean, look at this. This is like the crappiest denture ever. But the dude is so happy. He's so happy. I mean, I made a denture that I'm embarrassed to show, but I have a patient who absolutely loves me. And it's not because of my skills. Obviously, my skills are not that good. I marked a midline that's like 2 feet to the left. But I have a patient that loves me. And that's the thing about these implant overdentures. You're going to have so many patients that are so grateful. You're going to feel like you really changed somebody's life. And that's a really nice feeling. So before I end this lecture and move to Q&A, because we do have a couple questions here, I want to talk about 2 more things. And that's retention and maintenance. If you notice in those earlier slides, the metal housing that snapped onto the locator, that metal housing here, let me go back to that slide real fast. That metal housing that snapped onto the locator, it had a black retention cap inside of it, okay? That black retention cap that's inside of it, that doesn't have very strong retention. It's actually not even considered a retention cap. It's actually called a processing cap, okay? And so the way that you increase retention, let me skip this one real fast. The way that you increase retention is by peeling out the black processing cap and replacing it with more retentive caps. Now, most of your patients are going to be older people. Very few are going to be very young and robust. Most of them are going to be older people. And so I hardly ever use the most retentive caps. The cap that I almost always use is the pink one on the lower left there. And what it does is it provides very good retention, but it still allows people who are arthritic or people who are a little bit more fragile to still be able to pull their denture off so they can remove it occasionally, clean up around their implants, and clean up the inside of their denture. Very rarely do I use the most retentive caps, and that's just because a lot of my patients have a very hard time removing their denture when I use the most retentive caps. Now let's talk about maintenance, because maintenance is very important. Every time you have a dental implant placed, you have to make sure that that patient knows that that implant is not guaranteed unless they come in and have you clean it on a regular basis. And this is really, really important. People lost their teeth because of poor oral hygiene habits. That's just how it is. They lost their teeth because of poor oral hygiene habits. And as a result, that's why they lost their teeth. If you put a bunch of expensive dental implants in their mouth and expect them to take great care of them, you might be delusional. So what I would recommend is you tell them, listen, you got to brush these things, you got to floss them, you got to take really good care of them so that plaque and tartar doesn't accumulate around those implants. And eventually you start seeing gum recession and threads showing. I've been doing this for a long time, and I really, really think I'm good at it. And I still see gum recession and threads showing. I still see it. And that's just because people have failed to maintain their implants. And then so what I would recommend you do is just steal my hygiene protocol. All you got to do is go to my website, go to my implant handout, and steal my hygiene protocol. I think I even have my implant maintenance forms and my consent forms. Just copy and paste mine, copy mine and paste it on your letterhead so that patients all know when they agree to do this, that they're taking good care of this investment that they put towards their mouth. Okay, so about my hands-on courses. I'm doing two, one in the spring and one in the summer. One is going to be in Detroit, May 27th. The website for that is called profitonics.com. The other one I'm going to be doing is July 8th in Nashville. Both of these courses are going to be full. They're going to include the surgical component, the bone grafting, the tissue manipulation, the surgical guide fabrication. It's going to go into much more detail in using a digital scanner and making a two-step, two-appointment denture, which is just the coolest thing ever. So that information is also on my website. And then for those of you who don't really want to learn about implants, but want to attend one of my most popular CE events, that's the one on the left there. It's called a Happy Dentist Retreat. It's going to be in Chicago, July 29th and 30th. I've secured a yoga instructor, a foam rolling instructor, stand-up comedian. We'll have happy hour on Friday night. The whole point of this is for you to take your entire teams and make it an incredible team building, health, wellness, happiness, and some clinical CE type of event. And so if you're interested in that, please take a look at the website, thehappydentistretreat.com. And here's more information about me. My website, Be Better Seminars, it has all my handouts. And so please, any handout you want to steal, just steal it. I'm not going to ask you for anything. If you just want to grab my email and shoot me an email because you're not sure exactly how to handle the phone calls, how to market this better, whatever it is, shoot me an email. I've done this for a long time and I'm really good at it. And so I'd love to help you. And then if you just want to follow me on socials, my social stuff is up there as well. I really hope you all enjoyed this presentation. I hope you learned something. And I want you all to know that even if you're unclear about any of this stuff, I'm available. I'm later on in my career. I feel good about serving other dentists. And so if you're in a position where you want to do this more often, but you're really not sure, you want to make the investment, and you just have questions for me, shoot me an email. I'm happy to answer those. Let's go to the Q&A because we have 7 questions right now, and let's see if I can go through all of them. What type of rubber dams do you use? Those seem thick. These are nitrile rubber dams, and I don't know. So Mijin, M-I-J-I-N, could you do me a favor and shoot me an email? My email address is right there. So shoot me an email, Mijin, and when I get to work tomorrow, I'll take a picture of the box of my rubber dam box and let you know, because I really don't know I don't know the answer to that one. Okay. Next question. This is from Alan. Okay. What do I use for adhesive? That's actually a great question. I used to use my hard reline material that I used to use was from Parkel. Parkel had a hard reline kit, and the kit included the adhesive for hard reline acrylic. However, now that I've switched to using Zest locator products, Zest products, let's see, actually I might be wrong, but I don't think I am. The Zest product, their kit, they come with a adhesive kit, a hard reline kit that actually has its own adhesive. And I believe they actually have a non-adhesive kit as well. Though I could be wrong. If anybody here is a Zest representative, please let me know if I got that wrong. But I like the Zest product a little bit better. The consistency of the acrylic as I dispense it is a little bit better, and it's a little easier to adjust. Hopefully that helps, Alan. Next one, Jennifer. Is there age, years of being a dentist past which you would not attempt to place implants for overdentures? Jennifer, that's a strong, strong no. It's a strong no. I feel like as a dentist, we have an obligation to do whatever we can to take care of people who are suffering. The lab that sponsored this is the lab that I use, Dandy Lab, and they helped me make my my guided surgical guides. And what that allows me to do is, even with people who have a atrophied arch, people who have a very flat lower arch, people who, if you look at their panoramic x-ray, you're like, dude, where am I even going to put an implant? I like teaming up with a lab and finding that little bit of bone and having a guide that'll allow me to place an implant, even when a person has they've lost a lot of bone over the years. But Jennifer, we're dentists. We got to do what we can to help people who are suffering. And a person who has a flat ridge, they're suffering. Next one, here, let's see. Letitia, is there a specific reason why you don't drill a small hole on each well so the acrylic can escape once you seat the denture? Letitia, that's a great question. And I do that now. And I apologize. I apologize for not mentioning that during my presentation. That's called a vent. And I would say that probably for the first 10 years that I was doing implant overdentures, I wasn't venting. And now I vent. Here's the big kicker though, Letitia. You got to purposely vent. Don't accidentally vent. I accidentally vent when I drill so much that I pop a hole in the denture in a space that I don't want to. I would rather vent towards the lingual, where it's not going to be aesthetically displeasing, in an area that I can polish very nicely. So Letitia, I would say vent every time you can vent. Go ahead and make sure you have a little hole so that acrylic can escape. And that Zest kit, it does a really nice job of polishing that up. Next one, Jamie. Are the retentive caps universal, despite whatever implant system may be in place? If a patient presents with an implant overdenture you didn't fabricate, how do you know which replacement retentive caps to order? That's actually a good question. And frustrating for you, there are different locators out there. And so if a patient comes in with a locator and it doesn't quite look like the traditional Zest or Preet locator, then what you might want to do is remove that and replace it with something that you can actually recognize and that you know what parts are compatible with it. Now, in order to do that, you have to identify the implant. And there's a lot of really nice websites that help you identify implants. Implant Direct is a great implant identifying company. Even though I don't use their implants, I use Megagen. Oftentimes when a patient comes in and they have some wonky implant that I've never seen before, I'll go on Implant Direct. Also, different Facebook communities like Dental Nachos, they help identify implants for you too. You just take a PA and you post it up on Facebook and somebody will be like, oh, I know that implant. That's the, new OS 67 or something like that. And then you can call Zest and see if you can find a compatible locator for that. Priya, would you please send your website info again? Oh, it's Priyata. I'm sorry. Priya, if I'm just going to go to the previous, oh no, I can't go to the previous slide. Priya, if you go to my website that you can see on this screen, Be Better Seminars, all of my hands-on courses and my Happy Dentist Retreat courses, those are all listed on Be Better Seminars. It should be very easy for you to find. Ale, you asked, how much does your scanner cost? That's actually a really good question. My scanner costed $0. And the reason it costed $0 is because the lab that I use, Dandy Lab, they give the scanner for free. It's a fully digital lab. They won't take any PVS impressions. And so they want to keep their workflow very efficient and they keep everything digital. And in order to do so, they want all of their dentists to use a particular scanner. And so they gave me the scanner. Actually, they gave me two because I do enough lab cases with them where they gave me two. I think I probably am eligible for three. And so I don't know if I'll ever buy a scanner ever in my career because this is just too good an opportunity. Good question though. Okay, next one, Mijin. Do you prefer chairside pickup or lab fabricating? Mijin, great question. Always chairside pickup. There's the potential for error with lab fabrication. As you know, whenever you do crowns, there's the potential for error. If you pick up chairside, you are picking up that locator exactly as it's snapped on. I have done lab fabricated dentures where they send me back this beautiful denture and the metal housing is already in there and it's polished and it looks perfect. And then I snap it in the patient's mouth and it rocks. Always do it chairside. Maybe I'll change my mind in the future, but right now, no way. I do it chairside. Lauren Lipinski, is just saying thank you. Thank you, Lauren, for the compliment. I appreciate it. Next one, Rifat Malhotra. Why are there no exit holes? Okay, I think I answered that one. I only started venting pretty recently, and that's just because I was behind the trends, and I only started venting in the last year, but I do vent every time now. Next one, Salima. What type of implant do you use, and how long do you wait to load the implants with the denture? Okay, so I use MegaGen AnyRidge implants. If you're on your computer, jump onto their website, MegaGen AnyRidge. They have really, really beautiful, beefy threads, and the stability of those implants is fabulous. I also use a denture stability measuring device called a Penguin. And what the Penguin does is it allows me to measure how stable the implant is in place. And if that Penguin reading is above a certain amount, so for me, if the Penguin reading is over 70, I'm ready to load that right away. I don't load it for a single tooth, but for a implant retained denture, I feel pretty good about myself at that point. Now that's me. That's me. That doesn't have to be you. You might say, I'll still wait a couple months, and that's perfectly fine. If you're new to this, Salima, wait. Don't do it right away. Don't have to feel the pain of a failing implant, maybe because of your impatience. But I would recommend purchasing one of those Penguins because they're very helpful and they're great for documentation too. Priya was just saying, got it. Corona 2020. What's the most common instruction that you give to the patient after denture delivery? Great question. I tell them, number one, is that even if you get a denture that doesn't rub and create sore spots normally, you're probably going to have sore spots now because now this thing it's not going to move. I mean, there's no give. And so some areas that maybe felt nice and tight before are going to feel too tight and actually rub and cause some pain. And so my first instruction is, listen, I'm probably going to see you tomorrow or day after because you're going to have some sore spots. That's number one. And then number two is we really hit home maintenance. We tell them, listen, I got to see you back here in a couple months so that my hygienist can really do a good job cleaning around those locators, making sure no plaque and tartar accumulates around those locators and those implants. Lynette. As a hygienist, I'm wondering what hygiene instruments do you like most for your implant cases? Oh, Lynette, if you're still on, email me. Like, just do it right now. Go email me. And what I'm going to do is when I get to work tomorrow, I will take pictures of all of our implant maintenance hygiene instruments, and I'll send those to you. We do have a lot of pretty nice implant maintenance stuff. The one thing that I would recommend you invest in, or your dentist invest in, is something called an air clean. Air clean is just basically, it's like, it shoots glycerin or glycine or something like that out of a tip. It's actually attached to your handpiece. It shoots it out at a pretty high pressure, and it goes under the gums and really does a nice job with retention. But Lynette, email me, okay? Next one, Shannon. How do you feel about laser bacterial reduction around implants? I love it. I love it. I use my laser. This is what we do. We have a very nice implant maintenance protocol. You can steal that from my website. And when patients are still bleeding, So the hygienist has cleaned around it. The hygienist has used the glycerin. The hygienist is really doing everything to keep it clean, and it's just still really gross and bloody. They send them to me, and then I take a laser around the implants. And if that doesn't work, we actually make them perio protect trays to wear so that they're on a daily basis putting hydrogen peroxide around those implants. That was a really nice question. Andrew, did you have any imagery available before the patient pulled out with the reline, and did it hurt the patient? Andrew, it didn't hurt as much as I thought, and I think it's because the implant was failing. This was a patient who smoked pretty regularly, and I think that's why it happened. It didn't hurt as much as we thought. It looks terrible. Do I have any imagery of it? Oh, yeah, Andrew, I know what you mean. Do I have an x-ray of what the implant looked like? That's probably what you're wondering. Andrew, shoot me an email. I'm going to see when I get to work tomorrow. I'll see if I can find that x-ray. Cool question, though. Jacobs, did an overdenture case had to thin out denture very much to labial? What went wrong? What I'm wondering is, Jacobs, email me so we can talk about this specifically. But what I'm wondering is, did you make the denture after you snapped in all the metal housings, added the locators, or did you place the implants and then try to retrofit around an already existing denture? And if you try to retrofit, that's when you really have to thin out a lot. I mean, that's the suckiest part of this whole thing. And so, Jacobs, if you're still on, email me and let's talk about that a little bit more, okay? Sylvia C. What is standard of treatment for lower edentulalism? Is it 3 or is it 2? What about the upper? Sylvia, you're going to run into trouble if you do 2 implants because it's going to rock. There's going to be rocking. You need, if you have 2, you're basically creating a 1-line fulcrum and your denture is going to rock. Remember, this person, their bone and their gingiva is going to recess over the years. And so let's say you have a great implant in the area of 4 and 13, but you have no implant anterior to those. What's going to happen is there's going to be anterior atrophy, and over time, the denture is going to rock. So at least 3 implants, at least. Same for the upper, at least 3. I think it looks cuter on the x-ray to have 4 upper, 4 lower, but sometimes a patient just doesn't have the financial capability of doing that. So I do at least 3. Sometimes a patient can't afford 3, but they can afford 2. I throw in the 3rd for free just because I know what a headache it'll be for me to have to take care of that denture if there was only 2 and deal with all that rocking. Carlotta, Dandy, you said? Yes, it's Dandy. Go on their website. I think it's meetdandy.com. I know they sponsored this. I'm not saying all this cool stuff about Dandy because they sponsored it. I freaking love that lab. I mean, they're so helpful, and they're innovative and they're technologically savvy. So I really like them. John, do you torque the locator abutment before picking up the locator? Yes, John, that is a great question, and shame on me for not mentioning that. You have to torque it in, because if you torque it in after picking it up, then there's going to be that tiny change. You're basically torquing it in a little bit deeper. And therefore, after you pick up your metal housing is going to fit on where the locator was and not where it is after torquing it. And I appreciate you saying that, because I'm going to adjust my lecture so that I make sure everybody knows that it needs to be torqued in before the next steps. GSDM1, when you mentioned one-piece implants and stopped using them, would you mind sharing? Yes. I'll tell you right now, Juan, the reason I stopped is because I started doing this 12 years ago. And 12 years of snapping a locator, snapping the O-ring on, snapping it off, snapping it on, snapping it off, snapping it on, those O-rings, they actually wear. They wear. Like everything in life, they wear. But the problem is, because they're one piece, I can't replace them. They're attached to the implant. And that sucks, because now I have a couple patients who they had a beautiful case that they were really happy with for 10 years. And now they have these O-rings, not O-rings, O-balls coming out of their gums that are worn to the point where I can't get the same amount of retention from them. And that's very frustrating. That's why I don't use them anymore. Next question. By the way, hey, thanks for asking all these questions. Gosh. Ale, do you do a denture in 2 appointments? Do you still have to do a bite block? That's a great question. Bite block, I still have to do a bite block of some sort if I'm starting from scratch, meaning I don't have an interim. But most of you are going to have an interim denture. You're going to have something. You're going to have maybe the patient's crappy old denture, or you're going to have the interim denture that you made at the time of surgery. But you're going to have something. The only time I do a bite block is when I start from scratch, when all I have is an edentulous patient. But all other times, I take whatever denture they have, their crappy old denture or their interim denture, which is also pretty crappy. And I take a 360 scan, I send it to Dandy, and what they do is they send me a try-in. They go all the way to their try-in, and that's a really cool thing because I'm not a huge fan of using wax during the bite block appointment. Vanessa, you mentioned doing this for patients with very minimal ridges. Is there a limit on minimal implant size that is able to handle overdentures? So, that earlier person talked about those one-piece O-ball implants. Those implants were 1.8 millimeter diameter. Those were really small, and they worked. The only problem was they were one piece, and that's why I stopped using them. The mini implant, the lowest diameter implant that I currently use is the MegaGen Mini, which is 3.0, and it's not a one piece. It still allows me to, remove the healing cap and place their version of a locator on top of it. So mine is 3.0, but I've done cases as low as 1.8. In areas where the ridge is very low. But I would say get in touch with your lab. If your lab isn't able to handle this, get in touch with a digital lab like Dandy and send them the CT, and they'll really help you with that implant planning. Lab's name again and turnaround time. It's Dandy, and the turnaround time is ridiculous. It's like 3 days. It's crazy, the turnaround time. I'll do a crown on a Monday and I'll walk into work on Thursday and I'll see the crown. It's ridiculous, the turnaround time. That's not always the case. I think they ask for 4 or 5 days or something like that for crowns. For surgical guides, it's usually about a week, maybe 8-9 days. And for dentures, these 360 2-appointment dentures, they need about 2 weeks for that, I think. Gary, minimal cuff height. Minimal cuff height. I'm trying to think. No, there's not a minimal cuff height. Unless your implant body is sticking out of the gums, like in that one case, in Paul's case, where he had so much gum recession that the implant body was actually sticking out of the gums, then you have to use a 1 millimeter cuff. You have to use a 1 millimeter locator cuff height. Otherwise, though, hopefully your implants are buried a little bit and you can use 1, 2, 3, 4, 5 millimeter cuff height. Dr. Bailey, will this recording be available? Trung, are you on the call? Can we hear you? Trung?
Yes, the recording will be available tomorrow morning.
Awesome. Recording's available. So watch it anytime you want. Raphael, thanks for your experience. Oh, you're welcome. Thank you for the compliment. Andrew, great presentation. Enjoyed it. Oh, hey, I'll take these compliments. Thank you, Andrew. Sabrina, can you quickly review the 2 options for placing the temporary denture following the scan impression? Sabrina, if you're still on the call, I want you to email me. And I'm telling you, I don't charge money or anything like that. I don't do that. Email me and I will actually, I'll email you those 2 slides, okay? Raphael, how much do you charge for 4 implants and 1 denture? Trung, can I go back to that slide where I had all my costs?
Yeah, go ahead and share the screen.
Let's see, share. Oh, I see. Okay, I see what you did. Where is it? Okay, give me just a second. Sorry, I kind of messed something up here. All right, this one right here. I am charging, let's see, 6,000, then another 1,000. So we're at 7,000, and then another two. About $9,000 is what I'm charging for 4 implants and a denture. And that includes the interim and it includes the surgical guide. Lindsay, thank you. Hygienists need to know the proper way to clean them. Lindsay, you weren't the hygienist that emailed me earlier. Just email me again. I'll send you the same thing that I sent to the other person. Okay. And it looks like the questions are gone. Cool. All right. Well, it looks like 670 people are still on. I think you're all dismissed. How often do you switch out the attachments? Anna, it depends on the patient, but usually either every 6 months for their cleaning or every year. So every other cleaning. Awesome. Thanks, everyone.